6 hours. You may know a lot in advance, but it will not be the 6 hours that will make you an expert, but it will give you some information and some knowledge that makes it easier for you also to communicate with the radiologist and to read the reports and look at your images yourself and seeing whether it makes sense, and thereby you can say learn new things and communicate even better with your radiologist, which I think is important. Ashish has already been mentioned this, that you can go into to share the screen. Can you see my screen on your computers now? Yes, we can. Great, fantastic. So, and obviously those who needs what I'm writing here haven't done it yet, but that's an option that you can see it on the screens in front of you, and it may not be important right now, but it may be nice when we go through images at a later time point, where you may see that there's a joint here on the screen, but you can't see the details. So I think that will be helpful, particularly the further back you are. Right, so I'll move into the presentation mode again. Right, so and the differential diagnosis in that process. We'll also talk a little bit about monitoring, but I don't think that you have the capacity in here in India to do monitoring by MRI. We don't have in Denmark, and I guess that it may be a challenge here as well, even though it can be helpful. So what we do is run through briefly the most important part of the anatomy of the joints, both the sacral joints and later today the spine. Then what sequences do we use, how do we obtain our images in their offices. And that's where you can find on your laptop. We're not going to use it right now, so you can do it while we are talking, but you can also wait a bit. But there is this link, and if you copy that into your browser, then it will work. Copy it into Google Chrome. Sometimes I've seen that there comes some strange signs when you copy it in, then there is 3 funny signs before this HTTPS. So if it doesn't work, then try to go there and move those signs, copy it again and move those signs first. That has happened at some of the computers where we tried to help. But I think that looking at real images, running through them yourself and discussing them afterwards is helpful. So if you look at the agenda, then we are, as Ashish said, a bit behind, but we'll catch up, and we will be sure that we will have plenty of time for interaction sessions as well. But what we'll do is now introduction, then I'll talk a little bit about some of the key things in MRI, the normal appearances in anatomy and the technique, and the key pathologies. Then we'll have a quiz, that's the Kahoot thing, and then we will have a coffee break, talk about pitfalls and differential diagnosis. Then we go into the real images, the full scans, and look at that for a couple of hours or something like that, at least 1.5 hours plus. And then we have lunch, and then we do more or less the same for the spine, except that we have a little less time for that because ligaments are also important in this area, but the most important area is the cartilaginous part here. That's where we primarily see the inflammation. That's where we see the damage, erosions, ankylosis, and that kind of changes, as I come back to. And it's not flat like this, it's curves in all directions. So therefore it is a quite complicated anatomy, which can be challenging to look at. And therefore it's also important that the images are acquired in a reproducible way, and that's what I'm going to talk about now, how we acquire images. So, because you can obtain images in different ways. MRI is a technique that makes a lot up slightly. Here you see the joint, and you see that it's there, but it's not very high. And as you go through it, you will see that you won't see the ideal images that you probably have seen from your radiology department, where you have the whole sacrum more or less in one slice. Here you don't cut it in the optimal way. You have the ligamentous part here and behind, and you have the cartilaginous part here, but it doesn't look the ideal way where you see much in one area. The ideal way of doing it is like this, where you align, and then when you scroll further back, the joint will be higher and higher here and here, and then at some stage it will change appearance, where the cartilage, which is this dark gray thing you see on T1-weighted images, it will only be on the top and the bottom, and in the mid portion here you will see some white signal with some scattered black dots here and there, and that is the ligamentous portion. And the ligaments are black, but they are surrounded by fat, and fat is bright. I'll come back to that. So that's why it looks like this. And if we look at images obtained in that way, then you will see it here, then it looks much nicer. You're in the anterior part, you have the ilium, you see it first, then the joint starts appearing here in the front. You can see that you are anterior because you are inside the pelvis and see pelvic content like the bowels. And as you move further back, the joint becomes higher and higher, as you can see. This is not a normal joint, but we'll come back to that later. And after some time, getting higher and higher, then some things starts to happen here and here. And this is not an erosion. That is because we've come so far back that we are in the hole of the boomerang. You say that we have reached this area here, where you get into the ligamentous compartment. So when you go there, the further you get back, there's less and less cartilaginous joint. There's still a bit down here, but as you go further back, it will become all ligamentous. You're now outside the cartilaginous part, and you go so far back that you can see the spinal canal here. So that is the most important way of obtaining images, this semi-coronal or oblique coronal aligned with the sacrum. You can also, in addition, obtain images perpendicular to those semi-coronal slices. And they are called semi-axial. And they give a better representation of the ligamentous compartment. Some radiologists would say that it's very important. Well, there are two types of sequences that we're going to look at, and I'll explain more about this a little bit later. One is a water-sensitive technique, and there are several of those. The one that we most frequently use, because it's most easy to obtain and there's not much problems with it, is a stir image, which stands for short tau inversion recovery. Doesn't matter much, but it's an easy obtainable sequence where you make the fat dark and the water bright. But there are also other techniques like T2-weighted fat-suppressed images. And we generally say that when an image is T2-weighted, then you can see the water as bright. There are also some newer techniques like Dixon, but I won't go into that. And how do they look? Well, they mainly look like this. These are not very beautiful images, but they illustrate the point. This is a water-sensitive image, a stir image, where you see that water is bright. And what you see here is water along the sacroiliac joint. The sacroiliac joint is here, and there's water in the bone on both sides, indicating inflammation. The way you should find out that it's brighter than usual is that you should look at, okay, here close to the joint, this has this color, it's fairly bright, and then you compare with the color in the middle of the sacrum, or here, and you should compare. Look at this down here and say, okay, this is inflamed compared with this, then you'll be fooled, because sometimes the signal is inhomogeneous, so varying due to you say, inhomogeneities in the coil or in the magnet that you're doing, compare horizontally. How is it here compared to here, and there's no difference. This is inflammation, this is bone marrow edema, this is other examples of it here. This is better images illustrating the same thing, bone marrow edema around the sacral joint. And again, you see how nice images can be when you have it in the semicoronal plane. You can see three different intervertebral phenomena here, and it's easy to get an overview. Sometimes you will also see other signs of inflammation, but they're not as important. One of them is this thing that you have a line crossing here, which may be a little bit brighter. That's capsulitis. The capsule is seen here. It could also be down here. The capsule is here, and that can be inflamed in spondyloarthritis. This we see, but if we see a lot of inflammation up here in the soft tissues or out here outside the joint, then it suggests that it's a septic or infectious disease, which is characterized by spreading into the soft tissues. I'll come back to that. That's one type of images where water is dried here. You'll also see that the water inside the disc here lights up, and the normal discs have water inside it, and they are bright. Fat infiltration is another thing which we see. That is, when in the bone marrow there is more fat than usual, and we know that it occurs quite frequently when the inflammation as a straight line more or less down here. But here you can see that there is a hole going in, and so this is an erosion. The same you see over here. And the way it looks is a break of the cortex, a black cortex, going into the trabecular bone. The trabecular bone is what you see out here, where there's a lot of trabecula. The bone trabecula in themselves would be black, but there's a lot of fat between all the trabecula, and therefore it becomes white, because there's more fat than there's bone, even though it's called trabecular bone. But bone itself is always black. There's no signal from the bone itself. That's why the cortical bone is black and visible, because it's massive, while when it's a network with fat in between, then it will be bright. So this is an erosion, and it's defined like that. You have a loss of the cortical bone and a loss of the bright appearance of the adjacent bone curve. And this is again the same image as I showed you before, the normal joint. And here you'll see that there's not these irregularities here. There is a cortex running nicely down here, and there's no holes into the fat there. Again, I will take the attention to that you may have changes at this place where you go into the ligamentous part of the joint, the hole in the boomerang. Then it may. So, what we will do now is that you will find your Kahoot page. And now it closed before, so I have to open that again. And it's kahoot.it. I know I write com, but that's something different. Now it's 11684112, as you can see it on the screen. That's what you have to enter. And when you have entered that pin and pushes enter or whatever you push, then you'll be asked to put in a name. It doesn't need to be your own name, it can be whatever name, just so that you know who you are. And I can see that some of you are already getting so far. And We'll wait, give it a little bit of time while this is done. Sorry? The pin is on the top there, it's 1168412. So it's smaller now, I can put it in here as well, so it's also larger. So the one that is highlighted there is the pin 1168412. So I give you a bit of more time, 30 seconds more or something. Please, if you're not in there yet, then and if you have any challenges, then let me or Ashish know. Are there people who want to join who haven't got in there yet? Just raise your hands and we are waiting. There's still a few, right? Do you need help or are you doing okay? Are you on the way in? There's a few at the back, Ashish, back on the left. Do you need help? IT, then you can put in your PIN code, and then you can like where you are now. Yes, exactly. That's right. So just double plus 6841. So let's start. There's a few test questions first, and so if people, should be a few people who's not in there yet, then they will join while we are starting. That's not a problem. They will not be locked out. So there's a few questions. What you do is to answer the question here when the colors come up on your cell phone or here. So now you're asked whether you're male or female, and you have 20 seconds for each answer. And so please put in this on your Kahoot.it or on your cell phone. You only have 5 seconds left now. It doesn't matter whether you don't reach it this time. Right, good. Obviously, there's no correct answer here, or all are correct, you could say. But the challenge is that it's the idea is that when we get to the real questions, you will get points if you answer correctly, and you will also get points, a few points for answering quickly. But in the end, it doesn't really matter how many points you get. It's just for fun, so that we look at some images. But then you'll see that all answers were correct here. So then the quickest one was the one on the top here. So the next question is this, and again, you can't vote until I push next and the colors come up on your screen, and they'll do that in a second. Now you have the 20 seconds for answering. Actually, more or less means that it can only be this one. But explanation, what do we have on the right? We have an image where water is bright and where the fat inside the vertebral body is, and also in the subcutaneous tissue is dark. So this is a stir sequence. It could also have been a T2 weighted fat suppressed image, but there wasn't any option with T1 and T2 weighted fat suppressed. That's a long explanation, but it is important. Fat, bright, water dark in T1. On water sensitive images, water is bright, fat is dark. And we'll see that kind of images during the day, all the time. Right, and here you can see that something happens here, and you get different amounts of points. Then we move to the next question. So this is the next question here. Just give you a second to look at it before I go into the time you have for voting. So now you can vote in a second. And you now have 15 seconds left. So much of the sacrum in one area, and you would never do that in any other thing, because it's aligned. And you have 6 seconds left. Right, and you're almost all set to correct. In a stir water sensitive image, what is bright is bone marrow edema, and that's what you see. And the other lesions are, you would not be able to see fat infiltration on a stir sequence. That you need to see on the T1 weighted image, where fat would also be bright. So now we actually do move into a T1 weighted image. So this is the corresponding T1 weighted image, and you should only look at that one, not at the stir, which is just down here to illustrate it's the same patient. And here you have different options. And now you can go. And you have 6 seconds left. Right, and you answer the two logical reasons, and I think that's both are good answers, because almost all of you says that there's erosion, and then some says that there's also sclerosis. And I haven't mentioned sclerosis much, to be honest. I said that it was black on all sequences, and you do also see sclerosis. But the main thing here is the erosions that you see at different locations, indicating that it's the structural damage. Cirrhosis is black on all sequences. There's no signal from the bone in any sequences, and that makes it black. And that's what you see here on the top a thickened cortex. It's thicker than normal. Therefore, the correct answer is also with sclerosis. Right. Then I'm going to show you a number of cases where we will first ask you what you see, and afterwards ask you whether you think it's actually SPA or not. And there, as I also mentioned in the beginning, it's important. It's important not only to look at the MRIs, you should also consider whether the clinical history makes sense. Fortunately, it's not only MRI, we are also rheumatologists, and we have some work to do also with talking to the patient and examining the patient and looking at blood tests. So it's not one answer. MRI gives all answers. So you should consider the clinical context. So if you have a 65-year-old person who got disease 2 months ago, then it's unlikely that it's actually SPA. While if you have a reasonably young person, less than 45, who have low back pain and have had that for some time, 3 months, and there is sorts of inflammatory back pain with where it hurts more in the morning and less during the day when you exercise, that kind of stuff, then it's different. And that is important, very important, when you do your examinations of your patient and interpret the MRIs. So now I'm going to show you some slides, and to make it, you could say, understandable, it's all patients that are suspicious of having actual SPA, that they have the right age, and they do have some back pain, which has some characteristics of inflammatory back pain. So just that you have that in the back of your mind, it's not only the image, it's also likely due to the clinical history that the patient could have actual SPA. Right. So the first question is this one. So here you have a T1 weight on the left and a stir image on the right, and you should say what you think you see. Seconds left. Right, and you all agree actually that's very good in reality. You have bone marrow edema, that's probably the easy part here, and then, but you do also have some fat infiltration here, and you have some erosions here. And the interesting part is, now I actually do have the x-ray for this, and I'll find it to you in the break. The interesting thing is that this x-ray is 100% normal. There's absolutely nothing to see, illustrating that there is things you see by MRI and not X-ray. Yes?
Is that the capsulate on the left side, sir?
Is it?
The capsulate is on the left side.
Yes, that's good. Right. The question is whether it's capsulated on the left side. So the thing here, and that is absolutely correct. That's absolutely correct. And what you see here is there's a bright signal crossing from one side where you would have the capsule, and you, for instance, don't see it on the other side, and you most frequently don't see it, but you see it here. That's absolutely correct. Yes. And there is, yeah, that's it. Good. And that's just the same thing I just said. So now I come to this question. This is the answer, right? And then the question is here, given that the patient has a reasonable history, as I told you, how confident are you in this patient having SPA or not? Patient had actual SPA, and also most of you are definitely said definitely SPA, which I also think is correct based on the fact that you have the real good clinical history, you have both obvious inflammatory changes and you have structural changes. So you couldn't really have more, I would say. So therefore this is actually SPA. Then the next case you can see on the screen right now, and you should answer the same type of questions as before. So what do you see here? 6 seconds left. That's also very good. Bone marrow edema and erosion. And you're right, there is bone marrow edema here, both on the right ilium, the right sacrum, and the left ilium. And there is also an erosion which is easier to see if you do like this, where you can see a good example of the cortex running here. It's a bit irregular up here, but you wouldn't, if you only had these small irregularities, you wouldn't say it was eroded because you wouldn't be sure. It has to have a certain size, which I can't put a millimeter on, but that you're sure that it really goes through the cortex and goes into the adjacent bone marrow. And that's what you see here, that you should have the joint continuing here, but it goes like this. So there is an erosion there. And there's no fat infiltration. It is slightly brighter here, but not more than here, but it's not more than what we see normal, so there's no fat infiltration. And then the same question as before, how confident are you in this patient having actual SP? Five seconds. Great. And again, you answered well. You answered the two options. The majority was correct, and the next minority, the 11, the largest minority, answered what I would expect you to answer, and because it's a little bit of a tricky question. But there is fat infiltration. That's probably the easiest to see, and there's also erosions here, and there's also an erosion actually at this location. And the fact that there's an erosion there is the challenge, because I guess that those of you who said that bone marrow edema would say that this was bone marrow edema. That would be my guess. And it's actually not bone marrow edema because there's an erosion. So the bone has been destroyed, and thereby it's more waterous tissue inside the erosion. And therefore it's not in the bone anymore, and therefore there's no bone marrow edema. But again, the thing is, it's definitely still a good answer. Right. Then I'll ask you two questions. The first one is, does this image, does this patient fulfill the MRI criteria and the ACES classification criteria? That's a little bit difficult when I haven't explained to you what the ACES classification criteria for MRI is, but I'll do that later. But now let's see what you know. It doesn't matter, it's more for explanation. Seconds. So it should be a little bit unreasonable sometimes. That's how life is. So next question here is, what are present here? Three seconds left, so you're very much in a hurry. Right, okay, good. And here you also answer absolutely the two logical answers. The correct answer is ankylosis, and you see that, and where you have bone continuously crossing the joint space, like here and like here. So that's one thing. Then the question is there bone marrow edema? And I guess that what you think is bone marrow edema is that this is brighter than this, but this is actually the same color as what you have in here in the middle of the sacrum. This area and this area is more or less the same. So the reason why there is a color difference is that there's fat infiltration here, which makes it darker in these areas than the other ones. Not that there is bone marrow edema. Then the same question as before, is this SBA or not? Avinash is in front. Four seconds, 3 seconds. Right, and that was almost an unanimous vote, definitely SBA, and I agree. There is ankylosis, and there's even joint parts remnants, so that shows that there has been a joint space which has been destroyed over time. So I fully agree. And then the last case is this one. I don't think that it's homogeneous, and I think that it fades out more than it's sharply marked. But that's could be discussed. So therefore, I think this is the correct answer. And then we have the last question, which is the usual one with how confident you are. You almost have answered all of you, but there's 5 seconds left. Right, and I fully agree that this is actually SPA. First of all, based on the fact that I showed you the erosion, I showed you the backfill, and in reality there's more. There's some bone marrow edema here and there as well, and there is ankylosis down here. So it is actually SPA, for sure. You have many different signs. So thank you for that. And then, but now we'll see who were the podium here. There's actually some great music also. If it was on the, but Harish and Prakash was third and second, and on top is Avalanche. But the so congratulations to that. And the most important thing is not this is just that we got through it together, and that you hopefully learned from it and felt that it was acceptably fun. So with that, I think that we are actually moving into having a coffee break. Is that true, Ashish? 10 minutes? Coffee break is good, yes. So we'll have, let's see, it's 35. So we aim for being back here in 10, 11 minutes, and then we start again. And then we go to the most fun part, which is the where you have the cases in front of you. Because for some reason I didn't have this this slide in this deck, but this is just an example. You have seen the images, so I won't just do like this. So this is the image you've seen already in the quiz, but this is the X-rays, and it's just to illustrate that you wouldn't be able to make any diagnosis based on this, because the joint space is quite nice. There is probably some sclerosis around the joint here. It's not terribly much, but the joint space is definitely open and nice. And that is just illustrating the time advantage you see by, by having MRI compared to X-rays. Another slide I didn't show is a comparison with CT, which I can find if you want it. I can do that in the lunch break. But it's that with CT as a gold standard, CT is really excellent for visualizing structural components like new bone and erosions. It's very accurate for that, but not good for inflammation. And it gives some radiation, therefore we don't use it. But the thing is that if you use CT as a gold standard for, and then look at how good X-rays is for visualizing structural changes in the sacroiliac joint and how good MRI is, then you'll find that there are many false negatives on X-rays and much less false negatives on MRI. That means that MRI detects more. It has a higher sensitivity. It has sensitivity of 0.85 in a very nice study from Germany, while X-ray only had one of 0.48. So half of the patients are detected compared to CT, where almost 9 out of 10 are detected by MRI. CT is the best for this, but MRI is quite good. So there isn't really any, you don't really get any necessary information from X-rays we can't get from MRIs, except that it's of course much cheaper and easier to get done. Right, that's one thing. Then I put in a few more slices in the slides in this presentation on the differential diagnosis and pitfalls. First, I will just mention that before we had the ACEs criteria, then we only had the modified New York criteria for ankylosing spondylitis. And in ankylosing spondylitis, you needed to have one of these three clinical signs, which many will have. But you also needed to have this X-ray findings with bilateral moderate disease at least, or unilateral severe disease. And that gave a delay from symptom to diagnosis of 7 to 10 years. And then another problem with X-rays is that they are difficult to read actually. They are more difficult to read than MRIs. The agreement is poorer when you put experienced readers into it. And this is between two central readers in a clinical trial, and even they were, you can say they had as a side job to look at this, and they could still only get a kappa of 1.54, which is quite far. The ideal is 1, and 0 is like flipping a coin, so it's not very good reliability, particularly around differentiating between grade 2, 3 area. So therefore there's a new definition of this ACEs criteria, which is not that new anymore. It's 13 years old, which was published, and the ACEs, the axial spondyloarthritis term was invented. And in that, if you have this 3 months of back pain and less than 45 years of onset, then you could have sacroiliitis on imaging, and that would either be the X-rays, the severe X-ray changes, or inflammatory lesions on MRI, meaning bone marrow edema, and that was meant to be highly suggestive of axial SPA. And then one of these features, which our patients would generally have. So that's the definition, and thereby MRI suddenly had the opportunity to see things earlier than what you could do before and diagnose earlier. And it's very important that the MRIs need to be highly suggestive of axial SPA. And what is that then? That is an overall interpretation which will also take into consideration some of those features, some of the differential diagnoses which may resemble particularly the lower end, like degenerative changes in stress and strain, which I'll come to a little bit later. This you don't have to look at, just hear what I say. It is that the fact that you only in the ACEs criteria says there should be inflammation, that is not the best way for diagnosing, as we also talked about in the case which was ACEs MRI negative, but still for sure had axial SPA. in real life, in clinical practice, you should look both for the structural changes and the inflammatory changes, because they add up and makes it you're more confident in whether the patient has axial SPA or not. And this is just a study illustrating that you find more patients if you do both. And in the ACES criteria, which are done by the ACES MRI group, which I'm part of, then there was also an update some years ago, and they said also, or we said, that it is important when you have a little bit of information that you also look at structural damage. And that it's important that you not only look at stir images, but look at T1 and stir together, as we'll do here. So both structural changes and inflammation is important. And then also always consider the clinical context. That was what I said earlier this morning. You should not make decisions on a diagnosis based on only MRI. You should also consider the clinical context. And this is also in the EULAR recommendations for imaging in clinical practice, which was published now 7 years ago. And they suggest, and again, or we suggest, that at that time point that you should do X-rays first, unless, because that's also cheaper and easier. But in certain cases, such as young patients and those with short symptom durations, it may be better just to do MRI first, because you won't see anything in X-rays anyway. But of course, except for the radiation dose, there's nothing wrong in taking an MRI, taking an X-ray. But what it also says, which I think is important, is that if you have a suspicion of axial SPA, then you do an X-ray, because that's what you usually do, and that's also fine. But if you're not certain that the patient has SPA based on that, and you say, okay, there's nothing to see, then it's not correct in my mind to say, well, then you don't have axial SPA because there's nothing to see in X-rays. You would need an MRI to say that there's no changes, given that you have the clinical suspicion. And that's what it also says here, and that you should look both for inflammation and damage here, inflammatory lesions and structural lesions, like erosions. So that's the clinical practice part. And then that ultrasound is not useful for this. It's useful for many things, but not for diagnosing axial SPA and sacroiliitis. And secondly, that CT is good for structural changes, and it can be used. It's better than anything for looking at structural changes, but it doesn't give you the inflammatory part. I know there are new techniques with dual energy CT which you can adjust so that it may work, but that's not done in clinical practice. CT may be better over time as low-dose CT with less radiation becomes available, but still you don't have the inflammation. MRIs, radiologists just put it in a more simple way. It's a method of choice if you have the option. Then about differential diagnosis. Then I think that there are, you can say, two sorts of, differential diagnosis which are important. One are the severe ones, which probably our radiologists will find, and that is that you need to find. And that is tumors, infections, fractures, that kind of stuff. They're generally incredibly good in that, radiologists. But of course it's important to know for us as well. And then there is the other end. That's the milder things, where you may overinterpret images when there's a little bit of changes. And that can be things like degenerative diseases, anatomical anomalies with a little bit of bone marrow edema here and there. And it can be osteitis condensa sili after giving birth, for instance. And it can be stress-strain related things which we should not give a diagnosis of axial SPA. So I show a few of those. The most important thing, or most common thing that we shouldn't forget, is the degenerative disc disease. With disc degeneration, potential disc herniations, and that's much more common than axial SPA. I won't go into that because that's a talk in itself, but you can see disc herniations. And the only thing I will mention is that we do have areas of bone marrow edema also in degenerative disc disease frequently. And they lie generally along the disc, so following the length of the disc, so they are more flat than they are high. And that's what you see here. That's what you would call a vertebral end plate signal change, or some call it a modic change, a modic type 1 change, with bone marrow edema like this. Similar things can be seen in axial SPA as part of the disease, but it's not really possible to diagnose the disease based on that, because it could easily be degenerative disc disease. If you have it around a very normal disc like this one, which is with full water inside it, while this one is degenerated and has less water, if it's around a completely normal disc, then it of course suggests that it's inflammatory, while if it's around a degenerative disc, then it's probably degenerative, but it's not 100% thing. Then there is this condition called osteitis condensans ili, which is a mechanical stress-related condition. It is famous, you could say, for being found in postpartum women and in women who has given birth previously, which of course very many women will have done. And that's actually interesting. It starts pointing there. But it's pointing at something relevant. So this is the. That's interesting. What happened? Anyway, the area we're looking at, that is the area here where you have sclerotic bone. That's a typical sclerosis, osteitis condensans. So condensans is the sclerotic bone. You see that in the upper anterior part of the joint. Upper anterior part of the joint on the iliac side mainly. There can also be a bit on the sclerotic, on the sacral side, but mainly the iliac side. And you sometimes see a little bit of bone marrow edema around it. You can't really see that here, obviously. It's not only women. It's not only women. There are studies that have shown that it can also be due to mechanical stress in men, but typically women. On x-rays, when it's enough of sclerosis, it's very easy to see also as this triangular part, which is actually in the upper anterior part of the joint, the anterior end, but on the radiographs, due to projections, it is localized like this, as this triangle. It's an important differential diagnosis. Another important thing is stress. This is a study from Swiss rheumatologist who looked at a lot of ice hockey players which have a lot of physical contact when playing, and long distance runners. And he found that lesions like this this is the lower posterior part of the joint, of the ilium here. There you quite frequently saw things like that. And that could make you think the patient had actual SPA perhaps, because the patient may also have back pain. What he found also, and what has been confirmed in other studies, is that if here you have the sacral joint, and the most common places to have unspecific changes related to stress, strain, giving birth, whatever, is in the upper anterior part of the joint and the lower posterior part of the joint. These two areas. You can also have axial SPA changes there, but if you only have changes in one of these regions, then you should be very suspicious and say, okay, that's probably, it's so unspecific, it can very well be due to a lot of other things than axial SPA. While changes in the middle of the joint, the mid portion here, that's much more pointing towards a diagnosis. So you can have the changes, but they're not specific. We did a study with a lot of patients from different types, including axial SPA, but also around 40 women who had given birth and had pelvic insufficiency pain afterwards. I mean, they were poor. We recruited them from a physiotherapist who works specifically with such women. And we did MRIs, and then we also examined a lot of women who were just had given birth within 4 and 16 months back. This was a patient with post-pregnancy pain, and this was the worst case we saw. And that is pretty bad, because here you see it is in the anterior upper part, but not that much. And you see actually bone marrow edema, and there's actually also some erosion here and here. So we had one patient of this kind where I would say this definitely looks like axial SPA, but it wasn't. It was only 4 months after pregnancy. So the message is that take care about women, you can say when you do MRIs, who has given birth recently, they do have changes that may resemble the milder degrees of axial SPA. But normally, what we had many of was things like this, where you had a bit of bone marrow edema in the upper anterior part of the joint. And this is just resembling these cysts here and a bit of perhaps small erosion and that kind of stuff. So that you may see. But again, be careful with the milder changes in women who has given birth within the last, and I don't know exactly when it goes away, perhaps 1.5 years, something like that. But the sclerosis you continue to have, you can continue having forever. Then there's also anomalies, anatomical anomalies, and there are various, and there, for instance, here where there is an extra joint between the processus transversus of the L5 and then the S1. I also showed one I didn't mention previously during my talk today. But this is of course, this is abnormal. There may be a different mobility around such person's lower back, and therefore it may give some bone marrow edema, both related to that area, but it could also be further down here on the other side, because of different mobility. So is there a mild bone marrow edema somewhere in that joint, then say, okay, it could be due to this. If it's massive and looks like axial SPA, as in cases we had, then it's different. But mild bone marrow edema may not be due to axial SPA. The same is true for spondylolisthesis. You'll obviously find this one, but it may also give changes elsewhere where there's some bone marrow edema, for instance, in the sacral joints or elsewhere in the spine because of the different mobility. So when you have some anomalies, then you can say accept that there may be a little bit of bone marrow edema here and there, not massive amounts, but small amounts. This is an example of a patient who has this lumbosacral transition anomaly there with the processus transversus and the sacrum forming a joint. And then in the same patient, there were some bone marrow edema on the other side. And there was no signs of being axial SPA, so you may see that kind of things in your patients, and you shouldn't overinterpret it. Then you should, of course, always also think that the sacral joints are not the only part of the patient who is relevant. This is, I think that doesn't really look like anything like a sacroilitis, no matter how you put it, but still the radiologist wrote bone marrow edema in the right sacral joint of sacroilitis. So that's what we sometimes get. And it was based on this area here, which is very mild bone marrow edema. And if you only read that report, then you have a challenge, because then you would say, okay, well, perhaps this is sacroilitis, and well, perhaps it's actually SPA, so we probably should call it that. And first of all, these changes are too small. This is unspecific. It's the anterior upper part. It's unspecific. That's one thing. The second thing is that if you look here, and particularly if you take the next slide, then you'll see that there is massive disc degeneration between L4 and L5, and that is a good reason for having back pain, not this, and it's definitely not axial SPA. So you have to take care, and the radiologists have to take care as well. They will find this, but they still wrote this of sacroilitis, which was, I wouldn't consider correct. Then, moving into the other direction, that's the severe ones. There I'm less worried, and I think that we as rheumatologists can contribute less, because radiologists are, I think, very, very good. They've been trained for tumors as part of it, and they will find them, I think. But of course they are there, I won't go into them, and they should of course be found. Infection is also brought up, you say, is an important part. The classical infections have a different presentation with a lot of pain, fever, CRP elevation, leukocytosis, and then massive changes like unilateral severe inflammation. That's one thing. Unilateral severe a lot of bone marrow edema, and spreading into the soft tissues, like this. That's the typical. Here in the spine, massive inflammation spreading into the soft tissues. That's the key thing, and that will also be found when it's severe. The challenge is if it's more subtle infections. This is a case which I know it's very small. If you have a chance to look at, then look at your screen. I know it's small. Yeah. Now it starts making things here again. That's because I copied it in now because of the question. But that is, the interesting thing is, if you look at there where the red bottom, just stop this and do like this instead. That's better, and then we'll make it a bit larger. So here, this was the baseline, and it's a case story from Korea, and they looked at these images and found that there was some bone marrow edema, and there was also some erosion. It was even confirmed on CT. There was a bit of erosion, a bit of fat infiltration here, and a bit of bone marrow edema. And their final conclusion, you could say, at that time point was that this is probably actually XPA. That makes sense. And then the patient came back 12 months later and was still feeling bad, actually a bit worse. And then they did another series of images, and that's what we see here at the bottom. And there you will see that there is, first of all, again, a lot of bone marrow edema, but there now you also see the soft tissue involvement here. It goes outside of the joint. And you see also in CT that the erosions had progressed compared to what we saw before. So there is both bone marrow edema, soft tissue spreading, and erosion. And then they made a biopsy and they found out that it was tuberculosis. So you should take care, of course. But when you then go back to these images, then you could question whether it didn't look a bit like too much for a axial spondyloarthritis already at that stage. And they also admit that in their case. But I think it's a good example of that you should take care of the more slow infections. Take care of TB, take care of brucellosis, take care of that kind of stuff, particularly when you are in areas where it's more common than in other areas. So, but the spreading into the soft tissues are an important. So now I'll do this again. Right, good. So in conclusion around this, I would say that when you look at sacroiliac joints, it is first of all essential that I have said. And you should look both in inflammatory and structural changes, no matter what you see in some ACES criteria made for classification. There is a number of differential diagnoses which should be considered. It's not always easy, but I think that when you have a spectrum of patients from here to here, 100% here, then you could easily clinically find out a number of them, and then you have these where you're in doubt. And then when you do MRI, then you find some don't have XSPA, some do, and then you have restricted your amount of uncertainty. The patients where you're in doubt has decreased a lot with MRI. It really helps, but it doesn't mean that then you have no problems ever clinically anymore. You still have to think. Sometimes you have to say, okay, it could be, but it's not really convincing. Perhaps you can come back in a year if you're still feeling pain in the milder end. It happens, but it still helps you a lot. Think maybe because somebody has a microphone on, or I don't know. If you can hear where it comes from, then perhaps raise your hands. If you know it's your computer, then we can help you. Right. Then one thing I haven't talked much about, that's the ability to see changes over time. I'll talk a little bit about in the spine in the afternoon, but you can assess inflammation over time. And you can also, the more information you have in axial SPA, the better the chance of a biological therapy working. So that's we know that, but you may not always use that in clinical practice. But there is also needed a more research in that area to when you should do an MRI for monitoring. I'll come back a little bit to it this afternoon. So with that, I'll stop here and then we'll move into the cases. Any questions? While you're considering that, then open this, which is on your, if you haven't already done it, then it's the time to do it. Copy it in and raise your hands if you have problems, then we'll try to help you, because it's incredibly important that you get in here. That's the key part. Right. Okay, if you take this, you could click it, or you could just, in the Word file, then you could copy it to somewhere. I've copied it into Firefox, that's because it's the only browser where I haven't used it. You should copy it into Google Chrome, which you have on your computer. Then if you copy it up here, then you see it stands here on the top, and then you get into this one. Here, if you haven't done it already, then you should write something as a full name. It's fine if your full name is supposed to be something else, but the username should be something you remember, and your password should be something you remember, and you have to confirm it. Because when you've done that, then you can go to the login page. And in the login page, you'll then be asked to put in your login name, username, and the password. And when you do that, then you will get in. Now I have to cheat because I have it here as well. So you copy that in. And then you log in. And again, as I told you, sometimes I've seen it on some of the computers. When you copy it, it says some strange letters here before HTTPS. If something happens there, then copy it in again. Go and put your cursor here, or something like this. Then you just delete those. And if it looks like this, HTTPS, training code, blah blah, then you would get in. Right, then you should hopefully get into a page which looks like this. There's a lot of cases. Please let me know if you cannot go to there by raising hands, then we'll try to help you. If you don't raise your hands, we expect that you have found it. Ashish, there's more. Right, we'll run through some of this. People over here, please raise your hands again so that Ashish can find you. You think you first? Yes. This is fine. That's good. That's exactly how it should go. The one there, because it's HTTPS, something like that. It's, yes, so we have to copy it all. So because it's also all this, you can say, you need to copy the entire. So you should copy this. Control C. And then you're in there. And we can put it in the other one. And then there. And then Control V. And then it makes these strange things. There was one I was talking about. It does this, which I don't know why it does. These two signs. And now I would be surprised if it doesn't. It does. Then the important thing is you put in something there, a username, and then the password. Any name and the password. What problems? I would keep it yes, because when I run through the cases, then you will have difficulties seeing me running through them. Okay. Then you should, yeah. Yes, I know it. I just have to go and find it. But log on to the other ones. Have you found the web page? Yes, this one. Then you should find And now all the problems are solved, all the technical things, I'll never say all of it because things can happen, but hopefully the things are now solved so that we can work through that rest of the day. Here there's a number of cases, much more than we'll get through. What we will do is to run through some of the cases together, and I'll tell you which. You open the cases by clicking this DICOM viewer tab that is on the right of the case. Now I say to you, look at sacroiliac joint case A1. That will then be that you should click DICOM viewer out here. Now it will be exciting to see how long time that will take, now that we're so many in the room. But it works here at least, so hopefully it also works for you well. So this is where you should be. Then I have to explain you a little bit about how it looks. It may be that some of it is crawling to the next line here, but you have the different things up here, the different types here. There are an area here, that's where you look at the images, the large area here, and there on the left is the images that you can select. They're organized in sequences so that you have a T1, this is for instance a T1, this is a stir, they are both semi-coronal, and then there is a semi-axial sequence down here. That's one thing. There's some buttons here. The first one is instructions. If you click that, then you'll get instructions on what you should do. I will also tell you, but if you forget what I tell you, then you can look at the instructions, and if I'm doing something else, then you can also look here for all the cases. It says, create 2 windows, and then put in series 12 and 13. It says select 1 times 1 and change to 1 times 2. 1 times 1 is here in the middle of the screen, and some of yours it will be in the next line, but it says 1 times 1. There's an arrow on the right of that. You click 1 times 2 there. Then it looks like that. You can have 2 images. Then the way you get images in are by dragging them in the usual way by going to the first case. We said it was series 12 I should put in. Then you take this, hold the left mouse button down and drag it to where it was. Now it does it already, but it's drag that like this. Then you take the next one, that was said that the other one to the right window was number 13. Okay, then we take number 13, that's here, and take the upper image here. Then you keep the left mouse button down and drag it here. Then you have the right images. Then you can scroll actually, but it's better to be able to scroll both at the same time point. So you link the series by this button here called Link Series. Then you have to use, now you can scroll through the images. I know that it's a little bit more difficult with a touchpad than it is with a mouse, but you can do it. Now I'm actually doing it with a touchpad, so it is possible. But it's a little bit more tricky. It's nice to have a mouse, but unfortunately we don't have it. But it can work well with that. So you use, by using the touchpad, you can go up and down. An alternative is also that you use the arrow up and down image. If you put the arrow into the area, then you can use up and down arrows instead of the touchpad. Right. Hopefully you're here. Then there is, before we look at images, there's a few things I would like to tell you. If you keep the right mouse button down, that will be the right button on your below or above your touchpad. If you keep that down and go up and down, then you will zoom in or zoom out. I would advise you not to zoom in, and that's of course too much, but you shouldn't zoom in so much that you can't see the surroundings, because sometimes there may be something outside the joint which is relevant, but you can zoom in a bit if you want to. If you, on the other hand, put the left mouse button down, or the left button on your computer down and go up, then it becomes brighter, and if you go down, it becomes darker. So you can try that and see that it works. And if you do something where you get out of the mode and you can't get back, then you can press the reset button up here, just left up 1 times 2. So reset button can be nice, then you go back to the original position. So keeping down the right and left mouse button and going up and down, that will either make it larger or smaller or change the windowing. Okay. That's more or less what you need. You can also use the pan button here. That's the one that is here in the middle, says PAN, pan. Then if you want to move it, you put it somewhere strange, then you can also move it by that. You have to unclick that to get rid of it. Right. Then I'll explain to you what we do now. The last thing I'll mention before I do that actually is that on the very upper right corner there is a button called Score Images. If you go in there, there will be a series of questions for the different cases. They are, you could say, you don't have to answer them. It's more important that you look at the images. But it's nice if you do and at least answer some of them. And then when you've done that, and I say to you, please submit your votes or your scores, then at the bottom of this list of questions, there is a submit button. And when you press that, and not before you press that, but when you press it, it will be transferred to my version of this program, where I can then see who voted, not personally, but the amount of people that voted for one thing and for another thing. And then we have this as a starting point for me running through the cases afterwards. So therefore it's nice if you do it. If you don't get through all the questions, it doesn't matter. But I think we can try in a minute just, this is not this important, this case here, but we can try just for a few minutes in a second. But what I generally would like you to do is to, when you start with a case, and we have several, you will start from the anterior end. The interior end of the sacroiliac joints, they're all semi-coronal images I'm looking at. The anterior part is where you're inside the pelvis. That means that you have, for instance, here you have the bowels, and the ilium here looks, with some goodwill, like a lamb chop. So it looks like this. Then you're anteriorly. And here the joint starts coming on both sides, here and here. And then I would suggest to you that you move through it fairly quickly, so that you can just get an idea of whether there's a lot of pathology, things that catches your eyes. And then you go further back, and then you just do that, and then you go back, just to see, is there something massive that you think you should look at. Then you go back, start from the anterior end, look at the slices, look at both T1 and stir. Often you will start with the stir, but that's up to you. See, okay, do we have any areas with a lot of bone marrow edema? Because that's what we look for there. Or other signs, other fluid-filled things. And if you go through that, then you'll notice that the bone here, this is a joint space, that the bone looks quite nice on both sides. And as you go further back, that continues. There's not really any areas with massive bone marrow edema. There's allowed to be a little bit of variation, which is not necessarily bone marrow edema, where it's just mild changes in signal. On the T1, in contrast, that's where we should spend some time. That is the best sequence to look for anatomy. And all there you look for all the structural changes. And the structural changes is bone marrow edema. Sorry, that was the only thing I shouldn't say. There should be bone erosion, not bone marrow edema. Bone marrow edema is on stirs. So bone erosion, fat infiltration, and ankylosis and backfill. That's the things we were looking for. And then of course we also, when we look at things in real life, then we also look if there's something else that takes up space or other things. But here in the beginning, just look for those things. And if we look here, then you see the joint surface. It looks with a cortical bone, which is black, a cartilage, which is here. You can't see the difference. Two surfaces, that's, the resolution is not high enough for that. So you see, and then you see the cortex on the other side. And then you see the trabecular bone with fat in it, the bone marrow. And when you go through, you will continue looking for that. And you can see that the joint space here looks normal, it's smooth, look like rail tracks. On the other side, it's less smooth, but that's also normal. It should be more before you see it. It's curved. The shape of the joint space is curving in different directions, and therefore you won't always cut it just perpendicularly, which gives sharp margins. You have to live with the fact that it's sometimes blurred. It's 4 mm 6 slices, covers a lot of things, but it still looks normal. And particularly in the anterior area, you should take care. That's often unspecific, as mentioned before. And then you go through, and the joint becomes higher and higher and higher because you get further and further in. And then suddenly something happens here. Well, is there an erosion? Well, it could be an erosion, even though you can see the cortex. It could be, but when you then take the next step, then you can see that now it looks differently. You're inside the fibrous part of the joint here, the part where there's fat with some fibers in it, ligaments. So the neighboring slide here is just because we are getting close to that, and there's a little curvature there. So that's not an erosion. So it's when you see things right beside this ligamentous part, it may just teach you. It's just because of the anatomy. But you can still see cartilage here and cartilage there, cartilage here, cartilage there. When you then go further back, then you get further into the fibrous part with the bright signal with black dots in it. And there's only cartilage down here and here. And then you get further back and you're fully inside the joint, inside the ligamentous part where you don't really look for things anymore. If you're in doubt whether you're in the front or in the back, then if you go even further back, then you start being able to see here some water. And you can always go here to see whether it's a water sensitive technique or not, because in the very back you will see the spinal canal, and that will always contain water. So that's what you see here. So this is water sensitive, this is not water sensitive. T1 and stirred. And the images you're going to look at throughout the day is mainly the areas where you see the cartilage. So those before it gets into the fibrous part, because that's where the importance is at. I would like you to sit just for 2 minutes, 3 minutes, to scroll through the images and get familiar with the software, try to enlarge a bit and make it smaller, make it a little bit brighter and darker and that kind of stuff. And then perhaps answer the first 1 or 2 questions here on the side, just so that you see it works. You shouldn't spend time for all of it. And then we'll move on to real cases afterwards. Yes,
so this 4 picture, 4 image side, sir.
Please say it again.
How do we get this 4x4 image here on the left side?
You haven't?
Because the 2.
You only have 2, but that doesn't really matter. That's because you will not look at images there, you will just take the first image and put it in. So actually that's totally unimportant. Yes. So then there was, while we were waiting, there was one, that, perhaps it was you, wasn't it, that asked a question before that I didn't answer, or was it you? There was one of you that asked a question about the images where I said I would come back afterwards. That was you. Okay, sorry. I would think that you would have, when you get old, then the amount of irregularities on the surface and these cartilage and smaller irregularities are a little more fatty features. So therefore you should require much more to say this is an extra. Obviously sometimes patients do not, we have this rule of 45. Not all patients ever go to their end of the autologous before the 45. And it's not so that you can't get something between 45 and 50. But you should require more in order to say that this is a disease, because there are more unspecific changes. I don't think there's specific disease called, you can say, degenerative sacroiliitis. I think that some patients do have reality osteoarthritis, whereas in milder cases, milder changes than the more severe ones. And that is degenerative. But I also think that there are some patients which start their disease later. So if you have very, very convincing changes in MRIs and the clinical story makes sense, and I still think that it can happen when you're 55 and just rare. But you should require more. You say you should really research. That's what we would do. It's rare, but it happens. That's what I would say. But we. Ashish, you're there. When you have time, could you call here just to discuss timing?
Yeah. I'm
right. Good. So we'll look at what you responded. So I'll make it a little bit wider so that we can see what you wrote. So 34 persons have put in votes, and the far majority said bone marrow edema on stir, and again erosion are large, so you can also see them there, but again mostly on T1. Fat infiltration you can't see on T1. Sclerosis you would be able to see, and we can discuss whether it's there. T1 weight images, fat infiltration, erosion, sclerosis is, but particularly fat infiltration, erosion, you wrote it, and that I definitely agree with you. Whereas bone marrow edema, we'll come back to that, but it's mainly left sacrum, left ilium, you say, left sacrum, left ilium, yes. And then where's the fat metaplasia? Well, it's everywhere, more or less. It's mainly in the sacrum, that's all you say, but it's also elsewhere. I'll show you. Bone erosions, also a bit everywhere. Fat metaplasia and erosion cavity, you actually, more or less half of you says that it's in both thighs, and I'll come back to that, and I fully agree with that. It's not so easy, somewhere it's easier to see than others, probably more easy to see in the right joint. But we'll come back to that. Ankylosis, far majority says no, and far majority says certainly yes to XLSP. Good. Great. So, if we look at the case, again, scrolling through quickly, then the first thing that it turns out is that there's a lot of fat here, and then the joint looks strange, somehow irregular, and a lot of fat. And not because the bone marrow edema is picking up so much at the first sight, but there probably is something here and there. So a lot of structural changes. And if we take it slowly, then the first areas are always difficult. It seems to be a lot of fat infiltration already from the start, and that's present both in the sacral side and less, but present also on the iliac side. And it's very easy when you compare with the sacrum, the color. Then the joint overall definitely doesn't look normal. It's not normal. There are erosions and also irregularities which are not so large that you can really be sure it's erosions. But there's no doubt that this surface is not normal. Here you could say it's only irregularities. In this one, here there is an erosion there. And then there is two things which several of you pointed out 100% correctly, that, but also had some doubts about things like this and this. And it looks like erosion, particularly this one does. But when you go into the next slide, oh, that's the wrong direction, next slide here, then you'll see that you're inside the fibrous compartment with the bright signal of the fibrous compartment, both here and here. And therefore, this may be just, you can say, what we call partial volume artifact, that there is a bit of the ligamentous portion and a bit of the cartilage portion in the same slice, which is 4 millimeters thick. And thereby you get some blurring, and the straight signal looks a little bit different, a combination of the two tissues. And there we should be conservative and not score it as erosions, because we'd rather underestimate than overjudge. And there's plenty of other erosions to look at, but always take care in this transitional slice, transitional area between ligamentous and cartilaginous. What you on the other hand see here is backfill. And many of you also said that there was backfill at different locations. If you should follow the definition, which is having a black line like here, that's separated from the normal bone, and then some bright tissue, fatty-like, looking different than normal bone on the outside. Then this definitely fulfills the criteria, and that is backfill. The challenge is that in reality it's sometimes difficult to see the line. Here there is a line, it's not as obvious. So this is also backfill, but it can sometimes be difficult to see the black line. But you must see the black line before you can say it's backfill. And in the, I'll just show it on the other side. Then because if you have here, I think honestly I'm quite confident that this is exactly the same thing, an erosion which has been filled in with some tissue. The challenge is you can't see the sclerotic area, and therefore I would say no. I wouldn't say it's backfill. I'm confident that it is, but if I should score it, I would say no, because I would need the black line to not overestimate. Then you had a question.
Yeah, but would the backfill have erosion, sir? No. I mean, because the so-called backfill which you are committing on the right side, it also has got a lot of irregularities of the actual erosion.
Yes.
So is it actually backfill or fat, sir?
Yeah. So the question is that when we go back to this area here,
Yes.
it is said that you do have the sclerotic line, and it's accepted that this is backfill, but you say that the surface of the backfill area is actually also irregular. And is that then erosions? I would say no, in principle not, because if you have a large cavity that you've been digging, eating out, and then you start filling out from the bottom, that's a backfill. And then it may not be totally, you could say, straight. It may be that it does build in a more here than there, and it takes a bit of time. So I wouldn't call those irregularities on top of the backfill for erosions. The most important thing, you could say, when we use this in clinical practice, we're not scoring in a clinical trial where you're sometimes interested in seeing whether erosions heal or go away, and is it better in placebo or active treated. That's not what we're talking about in clinical practice. Then what we really want to know is, are we certain that this is an actual spondyloarthritis patient, and is there massive structural changes? And the answer here is yes. And this is definitely not normal either on this side, even though we cannot call it backfill. So we are discussing, you could say, some of those things which are important when you learn something, and but you could say in reality we just say severe structural changes with fat infiltration, backfill, and erosion.
The backfill which we are committing, we have to point out that the erosion, the original erosion from where the backfill happened, is that at the top.
So yeah, you say whether we should be able to see where the erosion had been. Right. Yeah. The challenge is that the case I showed when I went through there we had two sets of images, and then we could show the nice erosion first, and then we can see that it was filled in afterwards. But in clinical reality, you don't have that. Then you only have the post image, you could say, and there you just have to say that we know that when there is a black line that looks like this, then our experience tells us that there has been erosion to this side, and now it's being filled in because it's not homogeneous bone. So we should be able to see a black line and the soft and the bright tissue on the joint side.
So you want to say that it has so much big erosion earlier, and now it is filling up?
Yes, that is what it is. Because you know that from what we all learned in med school at some time, or at least when we became rheumatologists, looked at x-rays, then we know that we have x-rays. And there we learned that a stage in this, in many patients, is joint space widening. And that is where we have large erosions which eat the bone, and thereby the joint space is widened. And that's what we describe on x-rays. And then we accept that. And then we also accept that 5 years later, when the patient comes in, the joint is enclosed. And between those two phases, there must have been some new tissue being formed. And that's what we are to say, what we can now visualize by MRI, that this new tissue is forming. So it's actually now, it's being formed, and then the joint space becomes narrower and narrower and narrower, and at one stage it ankyloses. In some patients, not necessarily in all patients it becomes ankylosed, but in some it does. So that's the process. What we see on MRI is a bit more detailed. Yes?
In routine clinical practice, how frequently do you repeat the MRI? Is it every 3 year or 5 year or what?
Yes. The question is, in my clinical practice, how frequently do I repeat my MRIs? Every 3 years, every 5 years, that's what you said. In reality, we don't do it in clinical practice by any, you could say, regular interval. I would say that the most important part for MRI, if you have a limited access to MRI, inhibit that. But in clinical practice, it's mainly the inflammatory part. And when I use imaging for MRIs for following up, that's mainly when I have a patient, I have a initial MRI where I see there's a lot of inflammation, and then we may, after some NSAIDs and it's going poorly, then we may start a biological therapy. Then the patient, if the patient is doing fantastically, then I wouldn't do an MRI because it would treat the patient more than I would treat the MRI. So even though we have found something, I wouldn't change my therapy if the patient was doing well. But if the patient is not doing that well, and you're not really certain why it is that the patient is not doing well, that's why I would do the MRIs, because there I would then say, if there is a lot of inflammation left in that MRI after half a year treatment with some anti-TNF or whatever amount of months, 4 months, 6 months, whatever, then you can say, well, this drug doesn't work. It doesn't it decrease my inflammation. It doesn't take it away. We must try something else. But it could also be that all the inflammation had gone, but the patient had still pain. And then we have to accept, okay, it's probably not the inflammation that gives the pain. What could that be? Is it the structural changes the patient had? Is it something different? And then I would have a different approach to my patient thereafter. But that's the situation where I think that MRI can be very helpful in helping you finding out why there's still pain after you've treated. And then that can happen several times during the patient years where you're in doubt about something. But I don't do it on a regular basis. We do it in cohorts for, you could say, following up patients for partly research, partly being wiser over time, but not really for the course of the individual patient. Right. Okay, I think that was this case, and then I don't know, Ashish, are you somewhere? Not really, because I'm a little bit in doubt when we are about lunch things and all this, but unless, at least until he gets here, then we'll take the next one, which would be case 4. Devices do not fit. It is so that there are 16 stir images and 13 T1. So you should, in reality, take the stir image and go to, before you link them, you should go to image 3, and then you should link. So stir image 3 with T1 with image 1. If not, you will manage, but it's better. And then you should enlarge the stir image a bit. If you look at Zoom, and hopefully that's still on, I am, it is, I can see, then I will see if you have, some of you have answered anything. There's 5, that's not too many, but that's fine enough. So most of you said bone marrow edema, you can see in STIR. And regarding T1, you said fat infiltration and erosion mainly. And then bone marrow edema is located at all the different locations, more or less. Fat metaplasia is in all locations. 4 out of 5 says it at all locations. Bone erosions are mainly in the right ilium, but also a little bit elsewhere mentioned, but you agree on the right ilium. Backfill is said to be in the right joint mostly, a little bit in the left. Ankylosis is, you all agree or that there is ankylosing in the left joint, and you all think that this is certainly axial spondyloarthritis.
The STIR images don't show any edema.
Sorry?
The STIR images are not.
Not fine.
SA joint STIR images do not show any edema.
No, he is just telling the answer. He is discussing.
Bone edema.
You said, so I'm not saying that there's no bone marrow edema. You said that there were bone marrow. I haven't gone through the images. So I haven't come so far. No, I think I may have misunderstood, but I haven't run through the images yet. Now I'm just telling what your scores were. So now we look at them. I think that when you then do that you look through the images here. Sorry, I just have to. Then you say again the quick one. Then the first thing that appears to me is that there seems to be missing a joint space here on the left side here. So there is ankylosis, but let's come back to that. And there's also some structural change. This joint is very, very narrow. We come back to that also. And the question is there really bone marrow edema? That's a good question. We come back to that. The most striking thing is that there is, you say, ankylosis and lack of joint space here. And we take it slowly. Then already here, there isn't much of a joint space. You can at least somewhere follow the line across so that there is definitely ankylosis. There's also some joint left, and thereby I would agree with you that in certain areas you will find, you say, the normal bone down here, a black line, and thereby there's also a backfill in some slices in that way. So I agree with that. Some of you wrote this. There's also some fat infiltration at different locations. In reality, mainly in the sacrum, but also a little bit down here. It's close to the joint. It's not very, very homogeneous always, but it's definitely fat infiltration related to SBA. Then there's the erosion part. Then we have to accept that the funny thing here is that sometimes when you get erosions, and then sometimes you have this backfill, and you get this bright tissue like you see it here. But over here, there's not much joint space left, but you can't really see much backfill. Actually, there probably is backfill here, but it doesn't really fulfill the black line requirement. So you can't really score it, but it is structural changes here. So there's not that many large erosions to see. There's probably one there, and it's all irregular, and it's definitely not normal. It's definitely, you could say, related to actual SBA with fat, narrow joint space, but not that much backfill to see. So, severe structural damage, particularly on the left side where there's ankylosis and at many locations. Then there is an issue around bone marrow edema here, which is a good question actually, as because What is it here actually? It's very inhomogeneous, the signal. There are some bright areas there, but it's more or less everywhere. And then it's also a little bit bright there, and so it looks a little bit strange. And down here you see that this fat here was meant to be dark, but it's not really. It's too bright. So and you see that the tissue you see here, it's not really brighter than the fat. So therefore, I would say that it's a very poor quality stir image, and that's why I show it to you, because that's real life. So you should look at whether the fat is reasonably suppressed, and if there had been a lot of information, so that it was entirely bright, as in some of the cases I showed you before, then I'm sure we would have seen it here. But now you could say, my thing would be that, well, is a bone marrow edema that either there's no information or there is limited information. And if you don't want to know better because you have a clinical question for that, then do a better MRI. Then you have to repeat it and say that this quality is really not good enough because we can't make conclusions. There's no doubt about the diagnosis is obviously axial SPA and ankylosing spondylitis, and if you're happy with that, then no worries. If you need to know if there's inflammation in the sacroiliac joints, you say, well, images are not good enough to tell that for certain. And that happens also in real life, unfortunately. And then you can, by the way, also see up here that this disc is definitely not normal either. You have a disc here with bone marrow edema in the end plate and a very narrow disc. That's not the main purpose of this, but then you know. Right, then I think we should move on to another case, and then we should take B1. So case sacroiliac joint B1. So it's a little bit down here. There are 9, 7 or 8. Then you click that. So B1, SIJ case B1, and then in parentheses day 000. And there you do the usual stuff. Can you find it?
B1.
B1. I'll go up here in a minute.
B for Bombay.
B1. This one down here. Now you can see it on the screen home. So it's there where it says, you see it there as line 4, 8. This one. And there you do the usual stuff, that is putting in the T1 and the stir on left and right, making 2 windows and linking them. And then that here is the images. And you also have a set of questions on the right for that. because it's so intense. So you just skip this over here and look at the other joint. Then what you do is that you compare the signal intensity out here close to the joint with the signal in here, and then you say that it's markedly increased. And what is that, or you're certain it's increased, that it's just not a little bit of variation. And I know that's not an answer, because you would like to have a clear answer that it should be a color of this or that, so I can't say that. But it is that, for instance, you would say that this might be a little bit bright here, but that is not enough. So it is a little bit of experience, but if it is markedly brighter in an area which is not just a small spot, which would probably be something else like a vessel or something like this, or a cyst, then you say it's bone marrow edema. And I apologize, I can't answer more. There are some scoring systems which looks at they should have the same intensity, that there's something that calls intense bone marrow edema, and then it's as bright as a vessel. But that's not the criteria, so I can't tell a certain order, unfortunately. Right, so please put in your votes. So I guess you have done that now. There are 33, okay, that's quite impressive actually. 33 cases here, and they're everybody says that there's bone marrow edema. Quite a lot says erosion, a few sclerosis, and a few fat infiltration. I'll go back to that later. Most pronounced, almost everybody says bone marrow edema. Location of bone marrow edema, almost everybody says right ilium and right sacrum. Fat metaplasia, those mostly says no, which I would agree with. But those that say something say left sacrum or right sacrum. So bone erosion is on the right side, mainly right sacrum, and a few says right ilium. Oh, what happened? There it was. Then there's the ankylosis. Yeah, then you can say more or less half says that there's ankylosis on the right side, and the other half says that there's not ankylosis. I'll come back to that. And then what other features are present? And you can say the top runners here are soft tissue inflammation and unilateral inflammation, which I totally agree with. And then the majority of you says that it's probably not axial SPA, which I also agree with. And then majority says that it's septic sacroiliitis, and a minority says that it's actual spondyloarthritis. Great, I think that's a good thing. So when you scroll through these images, you'll see that it pops up that something is terribly wrong here in the right, or something's wrong here in the right sacroiliac joint with a lot of bone marrow edema. That's the first thing that catches your eyes, for sure. And then there's not much happening in the left side, but mainly the right, for sure. We take that a little bit slowly and go in a few slices. Then you will see that the entire ilium and sacrum is more or less bright. There's some bright signal also in the joint space, and there's also far too much bright signal here up in the pelvis on the inside of the iliacus muscle here, on the, between the iliacus muscle and the iliac bone. And there's also bright signal on the outside of the iliac bone. So that is this soft tissue spreading that you see typically in an infection. So it is an infectious sacroiliitis, and you have the three typicals: severe inflammation, unilateral inflammation, and spreading into the soft tissues. And then there is these issues about whether there's ankylosis, which I can fully understand why you say. That's because you can't really see the joint space in the T1. But the reason for that is that you have so much water here due to the infection, that there's lots of water in the bone, lots of water in the joint space, and lots of water in the bone on the other side. And then it gets the same color on the T1 image. It's not because it's ankylosed. And you can also see the joint space over here. So there's no ankylosing. What there is some erosions. There's one, it's actually this time easier to see on the stir, but you can recognize it here as well, that there is erosions. And there's one more down here, which is also seen here. And that is when you have a septic arthritis can develop very fast. It's an abscess that walks in, but it looks like, it absolutely looks like an erosion. It also is a hole in the bone. It's just from a different origin. So this is a typical example of a severe infectious sacroiliitis. And there's no bone marrow edema. There's no bone marrow edema here. Bone marrow edema should be, there's no fat infiltration, fat lesions in the bone. That should be bright on T1. It's definitely not bright here. And this over here is normal. That is, you could say, a little bit brighter, but not with very sharp borders. And if you say there's a little bit of bone of fat here, then okay with me. Perhaps there is, but it's not more than what you can see in patients now and then, normal persons now and then. Right, and I think that was it. There's no backflow because there's no bright signal in the joint space on T1 in any of them. Right, then I would like you to, unless there are questions, but this is important to remember how that looks. And it can be more subtle, of course, but it's a typical presentation. The last case we will make regarding this is B2. B2's SIJ case B2. And again, the usual procedure. T1 and stir on right and left. Yes. We haven't been through it. So, where? Yes, it could be, for sure. But what could it also be? Is it dark gray or is it black? We actually have it twice as white. Maybe actually better. Because it's probably better than this computer. Anyway, yeah, that's good. That's actually nice. Yes. So where is it located? Here or in the sector? It's an upper part more. Yeah, now an upper part more anterior. Yeah, I agree.
And when they not very confident in what is happening. Okay, I try to do this. It works. It does. This is much better. Okay, so you need a mouse. She said ask me, but they didn't get it. See now, if you look at that, is it erosion or it's actually you should irregular. Yes, but what is this thing here? Where is the joint space? Joint space is correct. So yes, from there to there. But is it erosion? Actually would be right. And see what. This one is C1. Yes, but that's just okay. Now I see, but it's not so bright, and there's not really an erosion because this is just a normal space. You can say that it's quite regular all the way through. But what is it next? Yes, but you can say what is black goes into water? No, that's on water it's dark gray. Water is dark gray, but black. You say this is not really like this. This is really black. But there are some normal joint space, relatively smooth border. Sometimes it's irregular in some of the slices, and then this massive sclerosis. You see the same on the third sequence. So, and what is black on both sequences? Sclerosis. Iliac side, anteriorly. You think of osteoitis condensalis, and that is a typical picture of this. As mentioned, it is a degenerative disease somehow, and thereby you can say there is also, you can say that that's also true. There is a bit of degeneration as well in that, or a bit of irregularities here, where there may be small erosions, but in here. But the main part is definitely the sclerosis. Then there is a question of bone marrow edema, and if we look at some slices, like for instance this, then you have an idea that this might be slightly bright, and if you go here, it may also be slightly bright in certain areas. So I would say that there is a bit of bone marrow edema, you can say here, and that is what that you often see that in osteoitis condensalis. The Berlin group made a study where they looked at it together with actually SPA and actually found that the far majority, about 80%, actually have some bone marrow edema when you have osteoitis condensalis. It also makes sense when you have a condition that is called osteitis. Then you more or less need to have about just a little bit of bone marrow edema on MRI to make it that name reasonable. That's not an argument, but you sometimes see it. Right, so this is osteoitis condensalis in the typical presentation, and it's not always as sick, but it's always in the anterior part. And it's mainly women who has given birth at some time point. So the first question when I see something in the anterior part is, when it's a woman, is has she had children? And if she doesn't, then then you have to consider why it is so, but it is often like that. Yes, with that I think that I would actually suggest that we move on to talk a little bit about the spine. Is there any sacral joint questions here on the, before we move to that? Right, then I'll move into that. We could have spent several days on this, probably you would fall asleep before that, but you principally could, and because I think it's quite interesting, fortunately. So I'll go and find the next presentation here. There it is. No, it's not. There it was. Good. So, we on purpose deliberately chose to focus more also Ashish and I on these sacroiliac joints because they are more frequently involved in early disease. But the spine is also of interest. There's 5% where it starts in the sacroiliac joints, in the spine approximately, and as time goes by, many patients do get changes in the spine as well. And therefore, it's of course also important to be able to recognize it. If you look at the anatomy first, then we're looking at vertebral bodies, which when you see them in this section here, then they'll be more or less squared with some concavity here on the front. You will have a ligament running here, the anterior longitudinal ligament and the posterior longitudinal ligament here. And then you have the disc in between with a core of soft mass and then the outer fibrous part here. So that's one thing. Then you also have other structures, which is the pedicle, which goes out. You can see that on this here. There is a pedicle going backwards on the side of the spinal canal. Then moves a bit like this backwards, actually like this backwards, and then it divides into forming a superior process going upwards, meeting the inferior process going downwards in a facet joint. That's what you see here. That's a facet joint. At the same time point as it sends something up and something down, it also sends something to the side, which is a transverse process. I come back to the transverse process. That's what we see here. And then when you've gone back like this, then it goes like this backwards again so that it forms a spinal canal in between here. And when it meets, it goes together backwards, forming the spinous process here. And you can't really see it here, you can see it backwards here, but that's not so easy. So this is spinous process. All these structures can be inflamed in ankylosing, and they are quite frequently inflamed. So it would be wrong just to look at the vertebral bodies. Particularly in thoracic region, there's one more thing. You know that we have the ribs, of course, in the thoracic region. They attach to the vertebral bodies here around the disc. Most of them, the upper and the lower ones are a little bit special, but they attach there so that they touch both the lower part of the upper vertebra and the upper part of the lower vertebra. So this area here, they go in. You say that's me here. This is my vertebral body. Then I have the transverse process there, and then on the lateral, posterolateral side here, there is a joint called the costovertebral joint, where the rib attaches or makes a joint with the vertebral body. Then the rib goes out here, makes another joint, the costotransversal joint. That's what you, to some extent, see here on the transverse process here, and then it continues around like this and ends at the sternum. Most of it was cartilage related to the sternum, somewhere out there. So, and the ribs and the costovertebral ribs, costovertebral joints are very frequently inflamed in axial SPA. And the transverse process and the joint here is very frequently involved. There's a lot of ligaments attaching to spinosus and the transverse processes, which can also be inflamed, giving bone marrow edema and soft tissue inflammation in those areas. So it's actually important. This is not so good. This just illustrates that you can have inflammation in all different areas. It's not so interesting. What you could use this for is to illustrate some of the, that in these outer fibers of the annulus fibrosus here, then sometimes there is ossification and you make new bone that is sedesmified, which then goes towards the next vertebra, and it can also fuse, making bridging sedesmified, and thereby you have ankylosis. And that's what you can see in the end stage of an X-ray. The spine where you have the vertebral bodies here and here. But then there's also a bridge here, that's the syndesmified, which bridges with the next syndesmified, and thereby it looks like a bamboo spine. Typically in ankylosing spondylitis, that is, you can say, symmetrical, and quite a lot of on both sides and several vertebrae. In other conditions like psoriatic arthritis, it may appear a bit different in that way that some of the osteosindesmophytes are more bulgy, like what you see up there, go a little bit up more to the side before it goes in again, and it's not as symmetrical. So it's an asymmetrical parasyndesmophytes or non-marginal syndesmophytes we see there. But this is a pattern. But this is late stage, of course. It should also be mentioned that it's a very fragile structure. It's not strong as a bamboo stick. It's very fragile and can easily fracture because there's nothing to, like the discs, to take the pushes they get. That's why we often see fractures. This you have already seen several times. We have T1 weighted images and T2 weighted images. That's what we use. T2 weighted fat suppressed images or STIR. That's what we use. And a typical axial SPA appearance, that is when you have inflammation in the corners. That's where the ligaments attach. That gives this inflammation starting here and then going out, forming this triangular shape or half moon, half sun, half circle appearance sometimes. So that's typical. These lesions I showed you sometimes when I was discussing degenerative disc disease and showed you that this was the modic 1 type lesion, and it actually is looking exactly the same, that you have along the disc some bone marrow edema. And that can happen in axial SPA, and that can happen in it happen in degenerative disease, and sometimes patients with axial SPA do have degenerative disease, and that's probably the case here also because the disc is narrow. But you can see it, but it's not typical. Then if you look through, now I just see that of course you have a lot of slices through. This is images of the spine, and when you look at the spine, this is a normal spine, and this just illustrates the entire spine. You can count from the top, this is C2, and then you can count the way down. Normally we obtain the images in either 2 stations, the upper and lower, or in 3 stations with 1 in the middle, depending on how much the MRI can see in one go. But now I'd like to show you which things you're going to look at. And here we'll focus on these 2 ones here, which is the T1 and the STIR of the lower spine, which goes from the lumbar spine up to mid-thoracic. And the thoracic area is where you see most in axial SPA, particularly the lower thoracic part, but you can see changes everywhere. So the way you start out is to looking at the vertebral bodies. Do they look normal here? And you find the mid slice where you can see the processus spinosus here. So you have the processus spinosus, and you have the vertebral body, and you have the disc. On a STIR sequence, the vertebral body should be dark. The discs should be bright, looking something like what the radiologist says, a happy burger sign, that you have a normal disc that's water, and then there is a darker line in between here. Then you have the processus spinosus, which should also be dark, and you look of course also for disc herniations, but this is not the topic of today. Then when you move laterally, now you're in the midpoint, then you move laterally, then it goes like this. And after some slices, you are no longer in the spinal canal anymore, and you get into the area of the pedicle, the one that went backwards like this. You can see that easily here. Again, it's easier to look at anatomy in the T1 than it is in the STIR. You have the pedicle going backwards, sending a process upwards and a process downwards, forming the facet joint, which is located here. And you can see that also on the STIR image. So it's behind the vertebral body. Here's the facet joint. And that is, if you had an inflammation there, then this area would be bright on the STIR sequence, just like it was in the sacral joint. If you move a slice further, then we are now on this, what I mentioned before, on the posterolateral part of the vertebral body. That's here. So if you had costovertebral inflammation, then you would have bright signal at this location, here, which is also frequent. So facet joint inflammation and costovertebral inflammation. And if you move further lateral, then you get out. Now you're so far out, we had the rib going out here. Now we're out here, crossing a slice like this through my trabecular, my transverse process, and the rib in front of it. There will be two round structures, far on lateral. That's what you see here. This one there is a transverse process, rib. Transverse process, rib. Transverse process, rib. And so forth, transverse process and rib. And that's easy to see actually. And if you have inflammation there, then you would have one of these circles here on the stir sequence would just light up a bit bright. And when you've done that a few times, it's actually easier than many other things. So thereby you've seen all the different structures that were interesting to look at. Now the only thing you need to do is to go to the other side and look and on the right side if you started with the left and vice versa. And finding the inflammatory changes are fairly easy actually. It's not so difficult as it seems. It takes a little bit of time. So that's how the spine looks. So again, the main advantage is that we can look at inflammation. And I have shown you exactly the same slide previously, but it's just that this is the same thing we look for here. Inflammatory lesions. Well, bright signal on the stir sequence. The same thing as before. I've shown you this image here with the vertebral body changes. Here on the right, two images here, that's more lateral. You can see you cannot see the spinal canal anymore, so you're lateral to that. And you see the area which I said before, the pedicle and the facet joint. Pedicle and facet joint. And here, this joint here is very bright. You can also see it is even dark on T1. So here you have a facet joint inflammation. So the most important thing is to find out where you are anatomically. That's a difficult thing. Thereafter it's quite easy, it's just bright. So that was the wrong direction. And this slide just illustrates, I'll skip it, but let's say that it's quite important, it's quite frequent, it happens as frequently as the vertebral body thing. So it's important also to look at the posterior areas like this. And here are all the different areas you can look at, and that can be done, and we have a scoring system for that will use it. But it's important that you look for the lateral things. And I think most radiologists do that nowadays, but 15 years ago, they just did the same thing as they do when they look for disc herniations. And then they only looked at this area, and then all the different changes you had out there would not be visualized. And that's not fair. You should do the entire spine so you can see, also go laterally so you can see the lateral changes. So here are the illustrations of the different pathologies. The discovertebral one that I've shown you before, the corners here which I've shown you before in the vertebral bodies. Then this is a beautiful example of an axial slice where you see the rib here, inflammation in the head of the rib and inflammation on the vertebral side. But on MRI it looks like, an MRI in the usual one, the sagittal plane, it looks like this. So inflammation here on the side. This is facet joint inflammation, I've shown you an example of that. And this is where you go so far lateral that you only have the transverse process at the rib. And these are too bright, while this one is looking normal. This is also too bright. So those are the things you would look for. And then I will skip a few slices, but show here a more difficult case, but just showing how images can look. Where you do have actually this spinous processes here, 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 and so far. But this is the bright area in this. So you do have bright here, have bright spine transverse processes. It's not as beautiful as before, but you can see it. But it's easier again when you look at real images. You may also see inflammation with bright spinous processes. Spinous processes are in the midpoint, right back, not on the sides. And then I'll jump this for now. Then you can also see fat infiltration in the same areas on T1, of course, because fat is seen on T1. Like these, and they come after inflammation has been resolved, and they are related also to development of syndesmophytes over time. Another examples here of fat infiltrations. It should be mentioned that because you have a few of those, you have not diagnosed actual SPA. It can happen also in degenerative disease, it can happen in different conditions. So unless you have really many, and the exact border is questioned, but perhaps 6, 7 of them, then you may be quite certain it's actually SPA unless there's a specific reason for it that is known. But a few of them you can see without having actual SPA. This is an example of the typical axial SPA performance, where it's in the corners at the insertion of the entices. The inflammation has gone away and you have this. They are higher than they are wide. Higher than they are wide in axial SPA, where traditionally in degenerative disease they are more horizontal because it's a disc that is ill. So there you see it more horizontally. So fat is common, not so specific unless there are really many. Typically they're in the corners and not along the disc. Bone erosion is not so important. It looks like the same as the other where you have holes in the bone. You can see it here, that some of the bone is missing here. Oops, it goes around here from here and there. But they're quite rare. It's a fat infiltration, the new bone formation, and the inflammation which is interesting. Last thing before we move on is the new bone formation. And that is, you could say, the syndesmophytes we know, those pointing towards the next vertebral body. And the way you can see that on MRI is just like in the sacral joints, a bright signal that goes in the direction of the next vertebra. The challenge is that this is not the strength of MRI syndesmophytes, because you need to wait until they're so large that you can see the bright signal inside them. When they're small and only like this, then they're difficult to recognize. When they're only cortical bone pointing in one direction, because they are black. And they are black in an area of the longitudinal ligament, which is also black, and therefore you can't recognize them because you're looking for something black in something black. So you need to wait till they're larger, and therefore you can say at these locations X-rays are actually better to see syndesmophytes at this location where X-ray can see it, and CT is the best. But it may not be so incredibly crucial for you to recognize these syndesmophytes, but it is not the strength. So then one slide I will just show you, because the interesting thing is that you can monitor inflammation by MRI. You can see here a case with a lot of inflammation in different locations, and then after treatment it's gone away with any treatment. That happens, and sometimes it stays there, and then I would say the drug doesn't work. So that's an option. It's not our focus today. So this is actually the last slide I'll show you before we take a part of the quiz, at least before we end. We say this is the parallel of the backfield sclerosis thing we had in the sacral joints. It's not so common here in that way that we see it, but here we see at one time point an erosion here with some dark signal across, which would be a elbow edema if you could see it, and then sometime later you're seeing that the erosion has been filled in and there is sclerosis. There is fat infiltration as well. So it happens, but it's less. There are less erosions in the spine, and MRI is not with the sequences we have right now. Some new are being developed, which probably will solve the problem. But as it is now, it's not particularly good for looking at syndesmophytes. So, I spoke a bit quick. I hope you're still awake. What I would like to do now in the last 15 minutes would be to do a quiz with Kahoot, as before. with some spine images. So that means you should find the way you did before, and then there will be a pin code in a minute. And there is a pin code there on the top, 3783432. I'll copy it in here. This question. Right? And this question. Now you answered it correctly before. I will just answer it. You've seen it before. It's the same as before, but please just go anyway. And that's the last question, which is not really relevant. Five seconds. Great. Yes, and now there is far majority for that. With water being right on stir and fat dark, and vice versa on T1. Good. Then, right. MRI is part of the following criteria. Which one? Which combination? I think you all answered actually. Climbs a little bit actually. Right, great, yes. The ACES criteria for axial spondyloarthritis, as I mentioned, includes MRI and X-ray also as an option for fulfilling the imaging criterion, allowing it to be diagnosed earlier. And here, but the modified New York criteria is only X-rays. So here, MRI is more sensitive than X-ray for visualizing sacral joint erosion, it should have said, and MRI is more sensitive than X-ray for visualizing desmophytes and lumbar spine, 1 and 2, or none of them. Five seconds. Great. So 1 and 2 and none of them. So there is a little bit of split vote actually. There is an agreement on the majority, on the right answer, which is that it's more sensitive for visualization. So that's for sure correct. MRI is more sensitive for visualizing desmophytes. Well, in the conventional sequences that we use now, it's never been documented. It's probably poor. At least it's not better. I specifically said lumbar spine because that's where radiographs are best. And I would say that it's much easier to look at it on X-rays. CT is the best. And there is some new sequences which we are working with that others also working with where it actually makes CT-like MR images, which I think will solve this issue, but so far the standard sequences, it's not the strength. So Vishai is in front, and this, what are the white arrows pointing at? Right, and there is bone marrow edema and fat dilation. Okay, right. So the first thing you should always consider is which sequence are we looking at, and the water inside the spinal canal here would be bright on a stir sequence. And thereby also bone marrow edema would be bright there. And on T1 it would be opposite. There water is dark and fat is bright. So the fact that the water here is dark shows you that this can't be water, because water has the same color both here, and it's dark here and white here. That doesn't make sense. So it's dark here, and what is then bright here, that's a fat, as also majority said. But that's important. Always find out first before you start seeing what things you're looking at. Saying first, which sequence are you looking at? And then you find out what pathology you have, because if not, you make mistakes quite often. So that's fat. So what are the arrows pointing at here? 3 seconds only. 2, 1. Good, you're quick in the end. Right, that's correct. So everybody says, or almost everybody, says intervertebral disc, and that is correct. That's here. And then the question is what this is, and the far majority says the right thing, that it's a spinous process. And it is a spinous process because we're in the midpoint. We can see the spinal canal, and this structure is pointing backwards, and that's the spinous process. The transverse process will go out to the sides and will not be visualized in the same slices as the spinal canal. So now this one. This one I actually haven't told you what this is. So so now it's at least a time point where I tell you. Five seconds, 2 seconds. Great. Right. That you knew, I can see. Good. Yeah, because at the back side there is a vascular, the vessel goes in, and that may be a small one like this, or you may not see it, or maybe a bright signal going as far in as that. And that is perfectly normal, and yes, so that's good. So what is the arrows pointing at? Ten seconds. Two seconds. Right, and here there's also a split decision, but a majority for the right answer. And the two things that are the top hits here are the costovertebral joint and the facet joint. And the right is the costovertebral joint, because this is this vertebral body that you see here and here and here. So, and the lateral posterior part of the vertebral body, that is where the ribs attach. So you don't see the rib, you just see the area of the vertebral body where the ribs attach. While the facet joint, that is further in behind, that's where you see the pedicle go backwards, and then you see something going up and down. So it's further back, it's out here, the facet joint is out here. So therefore, remember that the facet joint is behind the vertebral body. Smaller, I can see. Right. And when what is this then? This pointing at? And posterior, okay, you have radius. That's good. That's really good. That is the facet joints. And the anatomy is easier again on T1, but you see that here you can see the pedicle, at least here, going up. Inferior process, this area, the same seen on STIR image. So here you see bright areas around that, so that's a facet joint. And the posterior corner, I didn't talk about that, but that would be just as this is the anterior corner, then this is the posterior corner of the vertebral body. So, what is this? Five seconds. Yes, that's also completely correct. You have in hemangioma rounded structure with generally both more fluid due to the vascularity and also fat around the vascular area, so that it's slightly bright both on STIR on T1 as typically, and away from the corners or in the and it's not related to inflammation or anything. So it's just a coincidental finding. Quite frequent. So, which condition is this appearance most characteristic of? Nine seconds. Two seconds. Correct. Great. I'm happy to see that. You could say that most typical, this is definitely correct. You have, it's a T1 weight image, you saw it before, so it's fat infiltration in the corners and along the disc. But overall, it's mainly lesions that are, you could say, wider than they are high. And therefore, I would say that degenerative spine disease would be the correct answer. I'm not saying, actually, that it couldn't be ankylosing spondylitis or axial spondyloarthritis, which is kind of the same. Ankylosing spondylitis, you need to have the severe radiographic damage to have that. Axial spondyloarthritis is, you say, the overall term, both with and without sufficient structural changes in the sacral joints. Yes?
Could you throw some more light on Anderson versus Modic type 1?
Can you say that again?
Could you throw some more light on Anderson's lesion versus Modic type 1?
Yes, I can try that. So the question is whether I can throw more light on Anderson's lesions, which are the vertebral end plane bone marrow edema you see in axial spondyloarthritis and ankylosing spondylitis, or Modic type 1, which is the bone marrow edema that you see in vascular disease. In degenerative disease, degenerative disc disease, of course. Well, I talked a little bit about it when this is slide 268, just to go back to that. I talked a little bit about it up here. There. So, this is from a degenerative disc disease. And when you see bone marrow edema in a vertebral end plate, then it would cross, you could say it would, like this, then it would take
the width of the vertebra from the anterior end to the posterior end. And it would be bright because it's water. Then that would be look like this in the degenerative disease, and that would be called a Modic type 1, but it just illustrates that you will have water across here. That will be slightly dark on a T1 weighted image, and it will be bright on a T2 weighted with or without fat suppression. Then there will traditionally also be some disc degeneration because it's related to degenerative disc disease. So that's how Modic type 1 is. Modic type 2 is what we saw before when you have fat in the same area, you could say along the disc. So water is type 1, fat is type 2, but then what is the difference from what we see in axial SPA? And I also mentioned that you can say you can actually have changes that looks exactly the same in axial SPA.